All right, guys, so now what I want to discuss is lower respiratory tract issues. Now, keep in mind, the main focus in the lower respiratory tract function is going to be gas exchange. That's what's supposed to happen. The primary focus of the lower airways are to bring in air. We're talking about external respiration. When we take air from the atmospheric air, we inhale it inside and it goes inside of our bloodstream. And then the gas exchange, we're talking about, it occurs at the alveoli in this particular location. This is an example of the bronchial. These are two examples of the the alveoli, excuse me. And then you have the bronchioles right here. So we're talking about the mobilization of oxygen to the tissues. That's going to be internal respiration. So that's the main focus of the lower respiratory tract system. You need to have that as your foundation so we can start exploring potential complications and what happens when inadequate gas exchange occurs. Keep in mind that we also have this nerve that connects to the cervical nerves, and primarily we have the phrenic nerve that attaches to or innervates with the diaphragm, and the diaphragm is the muscle that helps push the lungs outward so we can exhale, and it contracts and pulls the lungs downward so we can inhale. That's essentially what's happening. So if you have any damage to the cervical spine, primarily C4, C3, C2, C1, you're gonna have some deficits in your respiratory effort because the diaphragm will not be functioning anymore. So again, I'm just trying to knock down some basic elements. Another important concept before we begin is that the brainstem, the medulla oblongata to be specific, is responsible for your respiratory effort as well. This is why ICP, intracranial pressure, is such an issue when it's secondary to a head injury, or whether it's a tumor or whatever's going on that's increasing the pressure in the head. It's going to affect the respiratory rate because your brainstem, your midbrain, your pons, your medulla, they all help and aid with the respiratory effort. And if there's something squeezing or causing pressure to those structures, it's going to alter your respiratory effort. Okay, so let's begin by talking about some of the most common issues that the patient is going to develop. Let's first discuss COPD. When we talk about COPD, I'm talking about chronic obstructive pulmonary disease. There's a few disorders. We have emphysema, we have chronic bronchitis and chronic asthma. And then we also have bronchiectasis. Okay, bronchiectasis is sometimes not included, but in some books it is. I'm going to go ahead and include it. Keep in mind that your COPD, your chronic obstructive pulmonary disease, is an umbrella term that we use to discuss these long-term issues with the respiratory effort and with gas exchange issues. So in emphysema, you have cellular damage to the alveoli where you develop scar tissue and where the elasticity of not only the alveoli, but the bronchioles and the main bronchial trees become damaged because of cigarette smoking or the inhalation of other noxious elements that can cause damage to the integrity of the respiratory system. And so gas exchange becomes impaired. Now, when we talk about impaired gas exchange, I really want you guys to focus on this idea. Impaired gas exchange. What I'm trying to explain in the impaired gas exchange is what happens when you have something get in the way of the gases becoming exchanged. Now, the healthy patient should be able to breathe in oxygen and perfuse the tissues and eliminate the metabolic waste which we call carbon dioxide. Well, if you're healthy, that's what's happening. But we're not talking about the healthy patient right now, right? We're talking about the unhealthy patient, the patient with COPD. Impaired gas exchange will lead to decreased oxygen, which we know as hypoxia or hypoxemia, and it's going to cause an increase in the metabolic waste because we cannot get rid of it, and that's going to be your increased CO2, and that leads to something called hypercapnia. Keep in mind that it doesn't matter what disorder we're talking about. If the principal pathophysiology is affecting the gas exchange, this is what's going to happen. Impaired gas exchange, the patient will become hypoxic and the patient will become hypercapnic. They'll develop hypercapnia, excessive CO2 levels. So in emphysema, we discussed that you have cellular damage to the alveoli, to the bronchioles, and to the bronchial trees, and that's why you have constant inflammation, you have scar tissue that develops, you have improper gas exchange, and this happens for a long period of time. The patient has impaired gas exchange, the patient will suffer from hypoxia, hypoxemia, and hypercapnia. Now, chronic bronchitis and chronic asthma. These can also be acute, but right now we're going to talk about the long-term, chronic, 6 months or more, right? Bronchitis happens when the smaller airways and the main airways become inflamed. Generally speaking, they're supposed to be open like this. We're talking about patency. Okay, it has to stay open. But in chronic bronchitis, you have inflammation of the smooth muscle of the airways, and you have excessive mucus production, which limits the passage of air throughout the bronchioles, the airways. And that causes impaired gas exchange, which will cause hypoxia, which will cause hypercapnia. Again, the same concept. Chronic asthma is usually secondary to some type of allergic stimuli, where your airway muscles, the muscles that are along the bronchial, the smaller airways, they become constricted and they narrow the passageway of the air. And so the patency goes away. And again, you have impaired gas exchange, hypoxia, hypoxemia, hypercapnia. You guys see the trend here? When we talk about bronchiectasis, this is a condition where the alveoli become damaged, where they lose their elasticity. They lose their semi-permeability. Now, semi-permeability is let's identify the foundation first. You have to understand that permeability is the ability for elements to pass on through a membrane, right? In this case, the membrane is the wall of the alveoli. Semi-permeability means that some elements are allowed to pass on through and some elements are not able to pass on through. Think of like a bouncer at a club. When you guys go to the club, you guys get all decked out, and the bouncer only lets who first? The hot chicks first, right? And then it lets the looking chicks. And then it lets the good looking dudes, and then it lets me in, and then that's how we have selective permeability. It's the idea that certain elements are allowed to pass on through and certain elements are not. In reference to the alveoli and its semi-permeability, it's supposed to let through only gases, or at least we're going to only be talking about gases for this particular example. So we're talking about inspiration, okay? O2 is supposed to come in, and when we talk about exhalation, CO2 is supposed to be let out. In bronchiectasis, the semi-permeability becomes altered, and now fluid is allowed to pass on through. And when we talk about the alveoli, now you have where the gas exchange is supposed to occur, again, the elimination of CO2 and the bringing in of O2. Well, you have a bunch of fluid inside, and that fluid prevents the gases from exchanging. At the same time, the elasticity, the alveoli is supposed to stretch out and they're supposed to recoil so they can allow the movement, the semi-permeability of gases to go to and from the blood vessels, the capillary, the alveolar capillaries. It's no longer happening because the elasticity of the alveoli is gone. And that's what bronchiectasis is. It's a chronic issue. It's irreversible, as are these other ones. And the patient's gonna need perhaps surgical resection of the segment of the lung that's no longer working because gas exchange becomes impaired in that location. I want you guys to think of concepts. Instead of memorizing all these different details seldomly or individually, I want you guys to think of the idea, the concept. All of these are chronic issues that impair gas exchange. The patient will suffer hypoxia and hypercapnia. Because this is a chronic issue, the patient's brain becomes accustomed to these hypercapnic levels and these hypoxic levels. Patients with COPD, they can develop SpO2 saturation that's anywhere from 88 to 92%. Now, this does not mean that it's going to stay there all the time. Sometimes it can get worse, and sometimes some patients, when the disease is not fully developed yet, it becomes a little bit better than 92%. But my point is that they are chronically hypoxic because of the impaired gas exchange. The patient that's hypercapnic, their CO2 levels, which normally dictates the respiratory effort in the healthy adult, well, now they get used to this hypercapnic level. the CO2 level that's supposed to be 35 to 45, but now it's a lot higher and the brain becomes accustomed to this value. Because of this phenomenon, the brain now looks at the O2 as a regulatory force behind the respiratory effort. And they get accustomed to having low oxygen saturation. And this is why you give COPD patients low flow oxygen, because since the brain became accustomed to this hypoxic level, if you give them more oxygen, then the brain will decrease its respiratory effort because it's feeling that it's being intoxicated with too much oxygen, because its driving force behind the respiratory mechanism has been altered because of this chronic issue of hypoxemia and hypercapnia. Hope that makes sense. Now, let's talk about some basic elements that we can include to keep the patient comfortable. First of all, if the patient is hypoxic, how do we position the patient? We must put their head of the bed elevated. So these patients with emphysema, with chronic asthma or bronchitis, or with bronchiectasis, they're going to be telling you that when they're sleeping, they're usually sleeping behind with a bunch of pillows behind them, because that props their head up. So their head of the bed is going to be elevated. It's not uncommon for these patients to sleep in recliner chairs that just recline them slightly, but they can still be with their head of the bed elevated because they have an inability to breathe well. That inability of the patient to breathe well when they're laying flat, what do we call that? Orthopnea. Okay, so your patients with CO2 are going to be suffering from orthopnea. And because we understand this, the head of the bed must be elevated in any way, fashion, or form, and that's going to promote better gas exchange, better lung expansion, which will make the patient more comfortable. Moving on to hypercapnia. Understanding that the patient is going to have high levels of high levels of CO2, we're going to promote specific type of respiratory exercises, and we call that pursed lip breathing. And pursed lip breathing prolongs the expiration, which prolongs the elimination of CO2, which is what we want. We want to get rid of that CO2. These patients are hypercapnic. So what we do is we tell the patient to take a deep breath into their nose, and then pucker their lips. You see how the exhalation, when the lips are puckered, are pursed like that, the exhalation is prolonged, and that's what we want to facilitate. We want to promote the expulsion of hypercapnia, the expulsion of CO2. Okay? Keep in mind that your patients that have COPD, their cells, all of their cells, let's just use the red blood cells because they're easier to draw. All of their body cells are working with limited oxygenation. So that means that what it would take you and I, the effort, the work that it would take you and I to take a few steps, okay, we're not short of breath yet, but your patient with COPD, those few steps are going to be very exhausting for those red blood cells that are working with limited oxygenation. So their cells all throughout their body, not just blood cells, but all of their cells are constantly working with high efficiency. The workload is greater because they have hypoxia and they're burning more calories. So your patient's going to be suffering from emaciation. Okay, they're going to be suffering from anorexia. They're not going to be that hungry. They're going to be burning calories. They're going to develop cachexia, profound malnutrition. So keep in mind that all of these elements that we're discussing so far go back to the idea that they are chronically hypoxic and they're chronically hypercapnic. You're going to be providing frequent rest periods when they're ambulating, when you're providing physical therapy, when you're ambulating or transporting the patient from one location to the next, you're going to be providing frequent rest periods, okay? These patients with COPD, it happens usually later on in life, so their expectoration ability is limited. Their ability to cough up mucus and phlegm is a bit limited, so we can do chest physiotherapy. And chest physiotherapy, I'm going to abbreviate it as CPT, is when you cup your hands and you bang away at the chest. And the whole goal is to knock off any of the mucus that's in the thoracic cavity for the hopes that we can help expectorate or cough up that mucus. So chest physiotherapy is really important for that. However, you have to consider some potential contraindications, meaning when would you not do chest physiotherapy? Well, if the patient has a flailed chest, which means that they have broken ribs, if the patient has intracranial pressure that's increasing, we don't want to do any chest physiotherapy. It's going to exacerbate the ICP. And if the patient has any type of, what's the word I'm looking for here? If the patient has any back or head injuries, which actually deal with ICP, okay? If you have any suspected spinal cord injury, back injury, head injury, your chest physiotherapy is going to be contraindicated because it'll exacerbate those particular conditions, okay? So when you think about COPD, folks, you can think of the concept. The idea is that gas exchange is impaired. The patient's going to have hypoxia, so we set them up for lung expansion. We know that they're going to have orthopnea, so they're going to be sleeping with pillows propped up, and that's part of our assessment, our data collection. You keep in mind that the patient has hypercapnia, so we're going to be promoting and educating the patient to participate in pursed lip breathing exercises to eliminate CO2. Okay, and keep in mind the etiological factors for all of these conditions, because you're going to need to know about them when it comes to the education portion for the nursing process. You have to be able to educate your patients about what's happening to these patients when it comes to the pathophysiology of these conditions. And keep in mind that anytime the patient has excessive mucus, we have to increase the fluid intake to liquefy secretions. But these patients that have COPD, they're constantly dyspneic, they're constantly short of breath. So make sure that you give the patient fluids in between meals. You hydrate the patient in between meals to ensure that while they're eating and if they're swallowing, they're not breathing. So every time that they swallow, they're holding their breath, or they're drinking, they're holding their breath, they're going to be gasping for air afterwards, and that might potentiate the risk for aspiration. So because of that, you want to give or provide fluids in between meals, but maintain hydration at least 2 liters per day.